All right, we'll go ahead and get started here, just to be respectful of everyone's time. Thanks so much for joining us for the last of the breakout sessions this afternoon, perinatal behavioral health screening, referrals, and resources. I'm going to introduce our speaker here in a moment, but just want to give you a couple of reminders. As you can see, the session is being recorded and it will be available on the conference platform about an hour after the session ends. We do want to hear from you in the chat. Feel free to ask questions or comment in the chat box on the conference platform. So back where you join the session, there's a chat box there that you can use. We recommend using the conference platform chat feature because the chat will be recorded with the session there. Make sure you keep yourself muted unless Dr. Whitney asks otherwise. And I believe those are all the announcements I have. So I'm excited to go ahead and introduce Dr. Whitney. She's been a psychiatric mental health nurse for 33 years. So lots of expertise and skill that she's bringing to the table today, and she has a fantastic session lined up for us. Dr. Whitney, please take it away.
Thank you very much. So I'd like to just share a little bit about myself instead of reading, my professional bio. I just want to tell you a little bit about my experience and what we're going to do today. So my name is Lucinda Whitney. Most people call me Cindy, and I have been a psychiatric mental health nurse for a long time. And my clinical specialty is actually child adolescent mental health, although I provide services across the lifespan. I have always taken care of children and their families, and you may know that when you do pediatrics or take care of children, you're actually taking care of the family. And I find that a lot of my time and energy, especially as I've matured in my practice, is really looking after parents, because when I look after parents and I take care of them, my patients, my children get the good trickle down. Okay. I have a practice currently at Kids TLC, which is residential treatment for children and adolescents age 6 to 17. We have outpatient services. I have provided telehealth for 7 years to a rural Kansas community. I have acute care services here in Kansas City in the Children's Psychiatric Hospital. I want to share that I became interested in perinatal mental health through my outpatient practice. And because I once took, before I got comfortable taking care of moms with perinatal mental health and prescribing, I used to say, well, gee, I don't think I can take care of you because my specialty is pediatrics. Until one of my patients, who also happened to be one of my nurses, came back and said, Dr. Cindy, if you don't take care of me, I'm not sure I'm going to make it through this pregnancy. So I had to get over my discomfort and get in the literature and increase my knowledge, skill, and my ability to be able to take care of that mom. So I hope that's what I bring to this. And as we go along, if you've got questions, I appreciate an interactive experience. So if you've got questions, by all means, pop them in the chat box, and Lydia is going to keep us organized and help us. Okay, so Lydia, let's go ahead and get started. All right, so this is Kansas Connecting Communities, Perinatal Behavioral Health Screening, Referrals, and Resources. Next slide, please. This is our disclosure statement. This is a HRSA grant. I personally have no relevant disclosures. Next slide. These are our learning objectives. We're going to talk about perinatal mood and anxiety disorders, substance use disorders. We're going to give you some context for when and how to screen and how to frame that up. And we're really going to highlight this plug and play approach that KDHE has with they have vetted and put together really phenomenal toolkits. So you've got some one-stop shopping. Okay, next slide, please. All right, here's just a really nice schematic for perinatal mental health issues. 37% of women have some kind of postpartum issues and some depression. You'll see 1 in 7 have pregnancy depression during their pregnancy. And so this really is significant. And we need to pay more attention to the moms and the mom-child dyad, as well as dads. We're going to talk some about dads. All right, next slide, please. All right, this is where you come in and the importance of the home visitor role because you are there in the home with the parent. Maybe you have a pre-established relationship, but you're there in the critical time frame, especially early on, and you're able to assess the mom in their most natural environment, which is often home. You'll be able to really address the importance of emotional and physical health for outcomes for both physical and emotional growth and development for the children. Another important role for home visiting is that pregnant women and mothers who have substance use disorders, because of the shame that's associated with that and the stigma, often have very little or no prenatal care. And it's really clear in the literature that mothers trust home visitors often more than they would before they would come and see me, or maybe even say something to their obstetrician, again, because of stigma. Next slide, please. All right, here's part of the plug and play. And I've taken just a couple screenshots so that it can be familiar to you. If you go to the KDHE website and really look at the perinatal mental health or the substance abuse toolkits, and in the toolkits, we've got, we're going to go over the content, but if you need help, like with the screening process, what are the screening tools? How do you implement that? How do you get a memorandum of agreement with other agencies in terms of referral sources? So it's all here for you. And so I've just given you just a couple pictures so that when you get to the right place, you'll say, oh, I recognize this. I'm in the right place. Next slide, please. All right, so we're going to start with, in thinking about screening, is really like organizational wide screening policies, right? And why you would do it. You're going to want to do it because it's going to improve health outcomes across the dyad. And when I say dyad, mom and baby, we're also going to talk about dads and babies. So parents and their children. We want to create access that is fair and equitable, and that people are getting, your clients are getting the minimum standard of care, right? It establishes the importance of integration into behavioral health. We want to help you to build capacity and workflows. And again, removing the barriers that makes this easier for you and your organizations to move forward. So questions you might ask, what is your organizational policies? And developing, like, what is the timing? How are you going to vet the tools? And we're going to go through some tools. What are you going to do about data collection? So these are some of the questions that you can kind of refer to back to when you're working on maybe bringing this into your practice. Next slide, please. All right, in the toolkits, there's even how to create a memorandum of agreement or understanding. And again, it's to establish collaborative care, okay, to assure that there's some community-wide standards for perinatal care that's being held to. We want you to work on networking and developing relationships with your referral partners. And of course, having resource sharing of resources and knowledge. And then of course, the questions that you can ask within your agency is, how do we establish these partnerships, and how do we, close that communication loop, and what are maybe the particular challenges that your agency would have? So in thinking about sort of moving forward with these memorandum of agreements or understanding. Next slide, please. Another important part of the toolkit is really how to establish community level education initiatives in terms of enhancing screening and referral and treatment for PMADs and substance use disorder. So really we want to have awareness and some support. Examples of support can be peer support groups, and we're going to show you some resources for that in the state of Kansas. Digital communities, meaning online resources. We're going to talk some about here's PSI is Postpartum Support International, which is a phenomenal organization that has a plethora of resources for clinicians, for parents, for community partners. And PSI Kansas, we have a very active chapter of Postpartum Support International here in Kansas. So the questions you're going to ask yourself are, what are the resources that are available to me? And are there any identified gaps that maybe you don't, or that the toolkit might not have the resource for, but how are you going to get that? And of course, we're going to talk about the consultation services that are available in Kansas to help you. Next slide, please. All right, community resources. You may know that there is a Kansas Support Group's website. And this is a wonderful resource for all of the support groups that are available, from grief, parenting issues, substance abuse issues, just mental health support. And I happened to just take a screenshot of their perinatal mental health awareness month, just so you could see what was there. But here you'll see that there's a support group toolbox. This is a wonderful resource that you may find a lot of resources that are online or even local that you might have not been aware of. Next slide, please. All right, so the Kansas Connecting Community Resources, the toolkits for implementing, there is a consultation line, and the consultation line is you can call and you can talk to a licensed mental health provider that will help you with the resources, getting the resources or the training that you might need. So there's direct to providers. So that would be part of the consultation line is getting a psychiatric evaluation. Connecting to implementation assistance and training, and then of course local partnerships and PSI that I mentioned a little earlier. Next slide, please. All right, let's talk some about the risk factors for moms and dads, okay? So a personal or family history of mental health disorders. So we could think about genetics as well as environmental influences and relationships and how that affects the parent-child dyad. Any kind of history of trauma, especially, think about relationship trauma. Like I work with a lot of parents and I'll ask them, like, when you were growing up, what did your parents teach you about being a parent? So they can have this, this relationship trauma. Other factors like history of infertility and women and couples who are really struggling with the burden of difficulty with getting pregnant and maintaining and delivering babies, hormone sensitivities, unwanted or unplanned pregnancies would be another level of stress. And then of course, just life stress with social support, moms who aren't getting enough sleep, if there's any conflict in the relationship and the intimate partner relationship, and certainly financial strains. Financial strains really affect both moms and dads, but really heavy on dads. We'll see that here in just a minute. Next slide, please. So I wanted to just bring in some new data and about the COVID-related risk factors, okay? So COVID is really considered a physical threat to pregnant women for the risk of their fears about the harm that will come to their baby. What if they catch COVID and transmit that to their fetus? What if they're exposed just going, being at home with their family and friends? What if they're exposed going to the doctor, right? Where there's more people who are potentially sick, right? And out of this research by Tillman and Associates, I thought this was significant that every person that dies from COVID, an estimated 9 others will experience the fallout of that from prolonged grief and possibly PTSD, right? I thought that was, and I have known people who have passed away from the consequences of a COVID infection. So, and I would imagine that the majority of you may know someone, have someone in your family, or, a friend of a friend. So I think at this point into the pandemic, we are all in some ways affected by COVID. Next slide, please. All right, so let's talk just a little bit about the risk of not screening for perinatal mood and anxiety disorders and substance use disorder to the dyad. Okay, so for pregnancy, there's poor health habits for mom. If a mom is depressed or overly anxious, not taking care of herself, anxiety and depression are risk factors for substance use disorder. And then there's also the risk to the pregnancy itself and to the baby. After the baby is born, the risk of bonding could be negatively affected, right? So remember, parents bond and babies attach. So with the infant, if the mom isn't attending to the baby, then there is this difficulty. Often children will have some anxious distress and like some avoidant attachment kinds of problems. But, early on, you'll see could have delays in the developmental milestones, maybe a little more irritable, difficult to soothe babies. Now let's talk some about substance use. And I think a lot of this is information that you have likely already been exposed to, but think about lower fetal growth, lower birth weights, maybe some complications in the pregnancy. There's the risk of losing the pregnancy. Alcohol, fetal alcohol disorder is the most preventable birth defect. Okay, fetal alcohol disorder, the most preventable birth defect. Recreational drugs. I take care of a lot of kids who've been exposed in utero to toxins, methamphetamines, marijuana, other illicit, substances. And they're often can be more irritable. They have learning and behavioral difficulties, more trouble regulating their own emotional responses. Infants who've been exposed to opioids may go through what's called the neonatal abstinence syndrome, where they've been delivered and then they don't have that drug in their system. And so sometimes those children will have more extended hospital stays. But if the child's kind of doing okay, this neonatal abstinence syndrome will kind of pass. And what we recommend for moms and dads is these babies need more snuggle time, more breastfeeding time if the mother's breastfeeding, so more contact and connection with the parent. All right, next slide, please. All right, let's talk for a minute about the difference between baby blues and postpartum depression, okay? So baby blues is really a feeling of sadness, and it's typically onset is 2 to 3 days after delivery, okay? And moms can just feel a little sad, not depressed, because there is a difference. And moms can still, though, have feel some pleasure and joy in having the baby, okay? Still can experience some of that. And so baby blues is really time limited. Okay, and they think it's really related to this rapid deceleration in, changes in your hormones after delivery. Okay, so self-limited, mother may feel a little sad, but not depressed. Mother's still able to function and have some pleasure with the infant. Okay, postpartum depression, typically onset 3 to 4 weeks after delivery. In my experience, I've really seen it right at 4, so kind of really holds to that. It is true that a mother could have postpartum depression much earlier, especially if they're, depressed in the natal phase during her pregnancy. Bipolar illness kind of is a little more complicated. We're not going to get so much into that, but you could really kind of keep this idea in your head, right? And postpartum depression, we think about that up until 1 year out. Okay, so it's possible that, usually you'll see it in that first month, but it might be 2, 3, 4 months out. Okay, next slide, please. All right, these are the common symptoms of depression and anxiety. So depression, sadness, hopelessness. Hopelessness is things are bad and they're always going to be bad. Okay, helplessness, something needs to change, but I don't know how to do that. Feeling withdrawn, worthlessness, certainly could have some mood swings, right? But they would be not sort of these huge mood swings, maybe a mood swing up into what would be like more of a hypomanic or manic episode. So that's where somebody has very activated, very energetic. Okay, we're not talking about that, maybe just different levels of irritability and different levels of sort of the depression. Okay, moms and dads can have trouble concentrating, can have appetite changes, whether too little or too much. A big problem is feeling indifferent to the baby. Okay, so you might notice as a home visitor that the mom just seems to kind of going through the motions, kind of doing baby care, or maybe not doing baby care at all, right? Everybody else is kind of taking care of the baby, and you might see that the mom or the dad is kind of emotionally flat and withdrawn, and you're going to wonder about, some of the bonding. I've heard a parent say to me, or a parent said to me, my baby doesn't love me, right? And I went, oh, okay. The majority of us don't have the assumption that the baby's going to love us, right? So that you might just pick up these little cues on what moms are saying. And moms can also have very anxious distress and can have a sudden onset of obsessive thinking. Okay, now often moms will have some kind of anxiety before, but it can be very intense onset of anxiety and distress. So I want to talk to you about something called harm OCD. And this is often very misunderstood. So I'm going to spend a little time on this. So harm OCD is intrusive thoughts of the fear that something could happen to the baby when I'm taking care of the baby. Okay. So that would be like, oh my gosh, what if I drop the baby in the tub while I'm giving him a bath and they drowned? Not, I'm going to drown the baby. Okay, see the distinction. What if the baby chokes when I'm breastfeeding and I can't save her? It's the what if. Okay, OCD is classically called the doubter's disease. Like, I doubt that I can take care of it. I doubt that I can manage this, right? So it's not, I want to drown my baby or I want to hurt my baby. It's, I'm afraid I might mess up and do something wrong and have a bad outcome for my baby. Okay. All right. So the other things that you might see is really just feel a mom just kind of going through the motions of the day and not being able, really, again, I'm going to come back to joy, feeling, even though you're tired and exhausted, the joy of being a new mother. Okay. Next slide. All right. I want you to know that dads can also have postpartum depression. Okay. And one of the biggest risk factors is if his partner has postpartum depression. Okay. So risk factors specific to dads, is this change in his intimate partner relationship, maybe feeling excluded, especially if there's breastfeeding. He can have some lower testosterone. Risk factors, I found it interesting if you have 3 or more children, right? So the dad's burden, think about his role, the role of being the provider or however he's been socialized. But having more children to take care of and feed is a major stressor for dads. Okay, next slide, please. Okay, screening 101. So what is screening? Screening is just early identification. It is a very narrow scope, okay, and it's just one piece of the puzzle, okay? Screening is not diagnostics, okay? So let's say Lydia is a screener. She's a home visiting screener, and she screens a mom and they have a positive screen and they're going to refer her. She may refer that mother to me for a psychiatric evaluation. And then I do the psychiatric evaluation and then we figure out a treatment plan. Okay. So screening is not diagnostics, right? It is just an assessment. And we'll talk a little bit about that because sometimes parents will worry, if you screen me, are you actually going to give me a diagnosis and a label? The answer to that is no. Okay. The importance of screening is really early identification and intervention and treatment. We also want to destigmatize and normalize mental health. And by doing this as a home visiting program, you guys see lots of moms. You have the opportunity to really introduce these concepts and decrease this idea that mental health is this other thing, that mental health is not mental health care is not a failure of character. I say that a lot to my patients who take it just so personal that they have a brain disorder that has psychosocial, is psychosocially mediated. Okay. We also want to enhance holistic wellness. Okay. All right, next slide, please. All right, this is the Edinburgh Postnatal Depression Scale, and this is the depression rating scale that is in the toolkit, okay? It is appropriate for men and women. Right? So it is 10 items. Once you become comfortable with it and it's easy to score, doesn't take hardly any time at all. And moms will will be familiar with this because if they've had natal care, they are being screened by their obstetricians, okay? They will, and if they are parents who have like younger children, the American Academy of Pediatrics actually says that mothers should be screened at well baby visits when the baby is 1 month, 2 month, 4, 6, 9, 12, 15, and 18 months if needed, right? Because it's at 6 months, if a mother's doing well, the obstetrician says, our time is done and now you're going to move back to your primary care and the infant's going to go to pediatrician or to primary care, right? So there's, I screen in psychiatry, so we screen in psychiatry, but also in primary care and pediatrics. Okay, next slide, please. So here's some quick facts about the EDPS. It's just 10 questions, and it is about a very specific time frame. How have you been in the last 7 days? There are 6 questions that assess depression, 3 for anxiety, and question number 10 is about self-harm and suicidal ideation. And again, this is validated for the use in men. Kind of the different clinical presentation between women and men is women are typically a little more internal and weepy, and men will be often a little more irritable or maybe angry. But that maybe just be like the subtle things that you're picking up, because in terms of just how maybe a mom or dad may be presenting in the home. Okay, next slide, please. All right, here's the EDPS. And just so you can see the questions. And the scoring is on the second page of the EDPS. And the one thing I wanted to point out here is a maximum score of 30. Possible depression is 10 or above. Okay, you're always going to look at question 10, which says the thoughts of harming myself has occurred to me. Okay, and the thoughts of harming myself, when that's positive, then that mother has to be, that's another data point where we're going to talk some, it's in the algorithm for how to manage what may be a crisis. Okay, here just in some of the questions you'll see here, questions 1, 2, and 4 are scored from the top down, meaning 0, 1, 2, 3. And then questions 3, 5, and 10, the scoring is kind of reversed. So I've just kind of highlighted it in blue there. And so that's just a reminder as when you go in, and the scoring is there for you, but just a quick little explanation there. Okay, next slide, please. Okay, here's some practical considerations for screening, which is just privacy. Where are you? What's the setting? Asking about confidentiality. Is it okay that grandma's here in the room with us? Transparency, again, why are we asking? Because in our agency, we find it important to screen mothers for perinatal mental health. And so this is a part of our standardized practice. This isn't particular to you, right? So that you can normalize the experience. You can certainly ask for permission, okay? And providing, and that's really inviting, that's being collaborative with your patient, with your client, and with agency, because they could say, you know, Lydia, I'd rather not do that today, and that would be okay. You can maybe say, well, you know, we might come back to this next time we check in, right? Language, you know, for us to make sure that we have cultural humility to be using native language to our clients or patients. And in terms of accuracy, it's important that you read the assessment tools verbatim. You might be able to clarify like one word or an item or something, but we want to make sure that you follow the screening because that's how it's been validated. Okay, and just in particular in the EDPS, we want to make sure that you use the Spanish version that was validated in Mexico, because there's several Spanish versions, and what we found in one of them, in the one that was from Spain, that there was a word that translated into kind of pitiful and being pitiful, and that was a very offensive concept to women from Mexico. And so we had to go and we vetted this and made sure that we picked the most agreeable and translation. And so make sure that when you're looking at that, and again, we've got this in the toolkit, but that it's validated in Mexico. All right, next slide, please. So here's just some conversation starters. You know, we want you to start early and introducing these concepts. We really want to normalize the need for mental health care and for screening. We want to promote people having a choice about screening and follow up for screenings, making sure that they have some choices in the treatment services that they may select. And we want to make sure people are aware that there's crisis protocols and other really relevant information about privacy and their confidentiality and what's going to happen with this information. And we want to also arm our clients and parents with access to resources, things that they can access on their own in ways that are both timely, convenient, because you know, a parent can get on their either their laptop, or a lot of these things are accessible through a smartphone, so convenient and on demand. All right, and then this slide is just a little more about the KDHE toolkit. So you can tools for talking about depression and even, more than baby blues. All right, next slide, please. More conversation starters. We wanted to just give you some language that you could just take and make your own, and really kind of highlighting, like there's just a lot going on, and being aware that mental health is an important part of your overall health. And just even like how to abstain from alcohol, just how to introduce these concepts and to really normalize them. And as you are comfortable with them, I find that the things that I am comfortable talking about, even when they're hard, that they land better with my patients. I'm able to instill some confidence that we can talk about these things and that we know how to handle them. All right, some other conversation starters just about how to introduce a screener, and maybe to say, there's just so much attention on your baby. I'd like to just really find out, how are you doing? So how have you been feeling in the last 7 days? Okay, and that's some of the tools that we're going to make sure that are available to you. Okay, and again, here, this questionnaire was not going to diagnose you with anything. There's not going to be a label. I just want to see how you're doing. And then from that, we can make some decisions about what happens next. So some way to just get comfortable so that you feel like you've got something in your back pocket and you're prepared to talk to these moms and dads. All right, next slide, please. Again, more conversation starters, maybe for the follow-up. Often when you find that a mom is really anxious, has all this anxious distress or depression, making a phone call can be incredibly hard, right? So we want you to think about making a warm handoff, right? So that would be my saying, now, Laura, from the screening today, it seems that you're really struggling with peripartum depression. That you're having postnatal anxiety or depression, and I really want to be able to help you with that. It may feel really hard to make a phone call. Would it be all right that I called Dr. Lydia for you and let her know that we did this screening together? I could actually even fax it to them, or I could sit here with you and help you make an appointment, just whatever seems appropriate. But to try to do a warm handoff, because we know that when there's a warm handoff, you have a much better chance of there being follow through, okay? Because often women tell me they want to make these appointments, but it just feels so hard to pick up the phone, to check, to look up the number, and who do I even talk to, okay? All right, other things about just providing support for the mom outside of the screening, like talking about sleep hygiene and breastfeeding and self-care. Okay, these are all really important conversations. Next slide, please. All right, this is just the introduction for the Edinburgh, and it is a sample script, and I've provided it here because the toolkits with the screening tools all have this sample script on them, okay? So it's actually on the form. So you can kind of read that. Now go to the next slide, because I think our next slide will show where it is in the screening. Okay, so here's sample scripts for the scoring, right? Less than 10, that mom's doing fine, okay? And you'll see down here, your response indicates that you're at low risk, okay? So the responses are here for you to use. And then as you get comfortable with them, we just wanted to make sure that you had a starting place and that you can take these responses and, kind of adapt them for your use. But again, giving you all the resources that you need to move more comfortably into screening. Next slide, please. All right, here is the workflow for a crisis intervention. So let's say you do the EDPS and it's got a score of 20. And on that 10th question, that mom says, yes, I am thinking about hurting myself all the time, okay? This is in the toolkit. So what happens next, right? So the client is having active thoughts of harming herself, himself, or others. Do they have a plan to cause harm to themselves or others? So you'll see no, and it's going to give you an algorithm. If it's yes, then you're going to move into the emergency services, right? And these are the things that you'll get worked out in your toolkit before you start. So what are the mechanisms in action to respond to that parent who may be at risk of harming themselves or someone else? Okay, Next slide. Next steps. So after screening, you're going to score it, you're going to interpret, and then you're going to decide what comes next. I did the crisis one. So let's say mom is, like a 15, her 10 was, I'm not thinking about hurting myself at all. Then, you're going to think about what is the next level. So if it's 9 or less, you're doing routine care. You're reinforcing that the mom's doing great. If it's 10 or above, you're going to think about what is a further evaluation and referral for assessment and treatment, and sharing resources with that parent, and then looking and thinking about following up with them about outcome for your next appointments. Okay. Referral planning, you're talking with the primary care provider or their OB. If there is, maybe mother doesn't now, it wouldn't be that unusual that mother didn't have primary care or an OB. You could touch base with the pediatrician. You could work on getting them an appointment at the federally qualified health center. An FQHC, what makes an FQHC a federally qualified health center is that it has integrated behavioral health. All right. And here is a great resource for you, which is the KCC Provider Consultation Line. So anyone can call the KCC line and say, I've got somebody who's in trouble, or I've got a mom who needs a psychiatric consultation, and I live in Phillipsburg, Kansas, and there's nobody I don't know anybody here. I'm needing some help. We have the capacity for telehealth to provide a psychiatric evaluation and recommendations for treatment, as well as even prescribing medications. It's a phenomenal resource for the community. Okay. Additional resources, PSI, Postpartum Support International. We have 2 Kansas coordinators, and I'm going to be happy to share my slides with you, because these are active links that go right to Melissa Hoffman, who is one of the coordinators. PSI support meetings, they have synchronous meetings at PSI for moms, dads, new parents, and free, okay, free. And then of course, we talked a little bit about the support group, candacelink.org, to look for resources that may be closer to home for you guys. And for some people, doing online telehealth is not for everyone. So some people want to do a little more face-to-face work. We can support you with that as well. Okay, next slide. So now we're going to start talking a little bit specifically about substance use disorder. Next slide. Okay. This new data just came out, and I pulled this one data point. And so you can read it here that methamphetamine use has tripled among heterosexual women in the state of Kansas, especially if you live in the southeast corner of Kansas, a real hot spot for methamphetamine use, which is where I practiced, which was in southeast Kansas. And it is a really serious problem. Okay, next slide. So why screen for substance use disorder? I mean, I think it's pretty straightforward. We want moms to be able to get the treatment that they need to improve their pregnancies and their outcomes for their children, okay? And again, as home visitors, moms with substance use disorder often don't trust the pediatrician or the obstetrician or primary care to really look after them because of the stigma. So they worry about legal consequences and substance use. So it is really clear. I've got a slide on this, but we're going to talk a little bit later about how getting moms in trouble for substance use disorder is not helpful in any way to the mother's health. Being in legal trouble does not decrease somebody's anxiety or depression. It actually ramps it up, and they have a worse outcome, right? So we really want to be able to take care of these women. And again, you guys are in the home in these critical early months. Okay, next slide. Just to really highlight, I think most people know this, but addiction really has a very strong biological component. It is a dysfunction in these neurocircuits, and it is a dysfunction that affects the reward, which is the addiction piece, and or the relief of the substance use. So when I work with patients, I often talk to them about, I think that addiction has a lot to do with feeling too much or not feeling anything. right? So people who are terribly depressed, who will often want to feel something, right? And they'll use an illicit substance to try to get themselves kind of up and to feel something besides numb, or people who have trauma or have are flooded with emotion and can't tolerate or handle their own feelings will try to suppress that with things that kind of bring them down and emotionally numb them. So I think about it as these kind of extremes of feeling too much or feeling too little. And of course, it's biologically mediated psychosocial issues. But I thought that this was a kind of a helpful definition. All right, next slide, please. All right, so I want you to know that screening always starts with care and concern, right? And care and concern can start with, because sometimes this is a hard conversation to initiate, especially around substance use. So I'll say, I'd like to talk to you about something kind of hard, but I don't want to upset you, right? And I'd like to talk to you about, substance use. Is that okay? So it's that invitation, and we're going to talk some about motivational interview and a little bit about Espert later on, but it is asking permission to talk to somebody about something hard. And I've never had anybody tell me no. Okay. Others, starting with care and concern, there's so much attention on your baby. I'd like to just check in with you. Okay. Or the reasons I'm asking these questions is to keep you and your baby safe, right? Other kinds of things could be like to standardize it, like we as an agency are screening all mothers and dads. Okay. All right, next slide. So here are some in-home indicators of potential parent substance use, right? You see paraphernalia, maybe you see a pot pipe on the kitchen counter, or you smell something on a parent, or their parent appears like they're intoxicated or under the influence of something, or that there are sort of these other, you might see with methamphetamine, especially like skin picking and sores. You'll see them on their face or their arms, or burns, on the insides of their lips from, smoking, or even the parent might self-disclose that they're having trouble or using. And then, of course, withdrawal symptoms, lots of, especially opioids, nausea, GI system is really kind of revved up, or maybe somebody's pretty inappropriately euphoric, or if they're under the influence of more kind of downers, slower processing kind of speed, or, even hallucinations. Okay. Next slide, please. All right, so I'm just going to cover the substance use disorder screening tools that are in the toolkit. There are a lot of screening tools that are would be clinically appropriate to use. These are the ones that were vetted and just included in our toolkits. The NIDA and then the assist. Okay, so here's the NIDA, which is the National Institute of Drug Abuse. And the nice thing again about these tools is that they have an introduction, so that you don't have to come up with the language. So here is like the introductory. The NIDA quick screen goes over alcohol, tobacco, prescription, using prescription medications for non-medical reasons, and then it says illegal drugs. And I think the word illegal is offensive because it's criminalizing. That's the word, but you might say street drugs, or some, you could, in my mind, change that one word, okay? Because I think it is off-putting for a parent. Okay, next slide, please. So here's the quick screen, right? If somebody says, no, I've not used these 4 things in the last year, then your screening is complete. If there's a yes on 1 or more days of like heavy drinking, then you've got to, at risk. If there's tobacco, one of the things with tobacco is we really want to help moms, and if you're screening dads, to help them to quit using tobacco. And there are good resources for free support and even free medication to help parents to decrease and stop their tobacco use. And then, of course, if there's a yes to any kind of illicit substances or using, say, opioids, then there is a modified the assist, which is what we'll look at next. Here we go. Here is the assist. And it is just 8 questions, and it takes, like if you're new to using it, probably take you 10, maybe a little bit longer, but when you get skilled at using it, you can do it very quickly. And again, the nice thing about the Assist in terms of doing the assessment is it's got the sample script here for you, and it's actually on the tool, okay? So some agencies will use paper and pencil, and some may, if you had an electronic, some form of an electronic record, it may become a part of the electronic record. All right, next slide, please. All right, here is the Assist algorithm, because it's of the questions, I couldn't get a good picture of it because there's several different, you have to hand your client an answer card, but there's just kind of a lot of content in it that I couldn't nicely get it into a slide. But in the toolkit, there is this nice algorithm to help you to figure out kind of what comes next. So with lifetime use, if they have no lifetime use, then you follow the algorithm. If it says, well, yes, I'm using tobacco, okay, and so then you just follow the screening tool and then the algorithm, and it will help you. Then you'll come back to what are the interventions. Okay, next slide. All right, let's talk a little bit about Espert. Espert is screening, brief intervention, and referral for treatment. And Espert really is standardized practice in primary care. Espert can be used for helping somebody move through any kind of ambivalence, because this is really about ambivalence. Somebody's ambivalence to change their behaviors, whether it's diabetes, decreasing smoking, increasing self-care, improving sleep hygiene. Can really use Espert for all of these interventions. The foundation of Espert, so it is an evidence base, but the foundation of it in terms of working with people is that you're asking open-ended questions, that you're offering affirmations for their experience, just like validating the person's experience. You're doing some reflective listening where it may say, well, Lydia, I heard you say that the good thing about smoking pot is that you kind of feel calm down after a long day. It's anxious and helps you get to sleep. And then I also heard you say, but you get really worried about, having to do a urine drug screen at work, or that people will find out and you might lose your job, right? So that's this reflective, this is what I heard you say was good about it, and this is what causes you trouble, okay? And then offering some little summary about the perceived benefit, the risk, and then kind of how moving forward. So Espert is in the toolkit. I bet many of you have probably heard about Espert. And so we have toolkits about how even to create in the toolkit, create the policies around it, choosing screening tools, and then even learning how to do Espert. Some really good online resources that have simulations, so that you can start to learn Espert and use it in your assessments. Okay, next slide. So that's part one, screening of Espert, and then the brief intervention, the motivational interviewing, the reflective listening and active listening, and helping a person, because behavior change comes not because I know better. Like I know I shouldn't probably eat 2 scoops of ice cream before bed, but I really do like that. Okay, so am I ambivalent about that? Is that causing me trouble? Maybe, maybe not. If it's causing me trouble and you can help me bring into my awareness what we call making this, moving into a decisional balance about, maybe that extra 10 pounds I gained in 2020 for, eating ice cream, maybe that wasn't worth it, right? So we can kind of move through bringing into my awareness the reasons inside me for change. Okay. And then the third part of Espert is helping refer someone to treatment. Okay. And this is again in the toolkit for your use. And again, you'll see here with the referral for treatment is really the warm handoff, and a warm handoff to include kind of up-to-date information regarding, the patient's care. And this is an interactive kind of experience, this warm handoff. All right, next slide. Here is the Espert workflow, which is also in the toolkit, so that any point during the workflow, if somebody's in crisis, you initiate, the crisis algorithm. But, you can use this algorithm to help you to kind of make some choices, or excuse me, plan your interventions, choices and planned interventions, depending on how the patient presents clinically. All right, next slide. All right, I think this, I was surprised to find this information, but Kansas has designated substance use treatment for women. There's both a federal mandate and a state mandate, which really prioritizes getting these moms into treatment. So the federal mandate, these women have priority to be assessed. So if you call, mom says, I want to go to treatment, you call, and the mandate says they have to be assessed within 24 hours and offered admission if it's clinically relevant, meaning they meet the criteria for clinical admission, that they have to be admitted in 48 hours. Okay. And then the mandate, even for mothers. So think about mothers who maybe their children are in the foster care system. So even a mother who's does not currently have custody of her children, but trying to get her children back, these mothers have priority. All right, next slide, please. So let's talk some about the dilemma of reporting mothers. Okay, so here I mentioned this earlier, but I'm just going to read this. Drug enforcement policies that deter women from seeking prenatal care are contrary to the welfare of the mother and the baby. And that's from ACOG. And that's true because being in trouble, if someone is in a lot of trouble and has already lost their children, being in more trouble is not a corrective experience. Same thing's true with children. Adolescents can be in so much trouble that they don't see any way out of their trouble, so that being consequented more heavily does not propel them to change or to correcting themselves. Okay. All right. Please do not report pregnant women who have substance use disorder to the authorities if they do not have any living children in the home. So if it's a first-time mom and she's pregnant and she's addicted to opioids, get that mom into treatment, right? So there needs to be a live birth or a child in the home for that to be potentially reportable. Keep in your mind that some mothers can use and still take care of their children. Okay. The time that you would report is if that mom really just cannot function in her mother role. And the children, the electricity's off, there's no running water, the children haven't gone to school, okay? The house is filthy. And even if the house is filthy and that was it, you would get some help to clean up the house, right? You invest in the mother, wrap care and concern around that mother to help bring her up so that she can take care of her children, take care of herself and her children. Okay, next slide, please. So treating perinatal mood and anxiety disorders and substance use disorders. So I want to talk to you a little bit about medication, and we've got another slide, but 1 in 7 women take an antidepressant, right? And we know that when women discontinue their antidepressants, because often they'll get pregnant and that's the first thing they'll do, like, I can't take any medications. If that mother stops her medication, she's 5 times more likely to relapse. And a mother who has untreated mental health has very poor outcomes, right? Through the course of a pregnancy, we know that the anxiety and tension of intimate partner violence, of untreated mental health issues, is transmitted to that baby. Okay. 9 out of 10 women in the US take some kind of medication during their pregnancy, not just psychotropic medications. Okay. And we know that psychiatric medications, well, you may know that unless a medication is FDA approved for pregnancy, that what we learn is through the animal model, meaning what research was done on animals to determine exposure to medications in terms of to the fetus and, for outcomes. But we have a lot of data on treating mothers and in terms of, and collecting sort of this, the data about how did mothers do when they're on medicine, how is medicine transmitted to the baby, both through pregnancy and even through breastfeeding, okay? Women who have a substance use disorder can be treated with medication, bupropion and methadone, okay? Or buprenorphine, excuse me. What I said before was an antidepressant. But so these medications, it is better for a mother who has an opiate use disorder to be treated for her disorder, and for us to get her as healthy and functional as possible with prescription medication than having her suffer or treat herself, okay? And for you to come away, for this slide, the takeaway point is down at the bottom. It is best for pregnant women to continue their psychotropic medications, okay? And in the toolkit, the KCC provider line, we have resources. So you can call and touch base and talk to someone. We have pharmacist presentations. We have advanced practice psychiatric nurses, practitioners like myself. So you can get lots of information and assistance in thinking about how to prescribe medication. Well, how we can support those who do prescribe medication. So you can tell moms, you can continue your medicine. It is better that you continue your medicine and feel well than to stop your medicine and fall apart. Okay. All right, next slide. I think we just got a couple minutes here. Okay, let's talk some about the health resources. I've mentioned the provider consultation line throughout the presentation. So you can get care coordination and psychiatric consultations with advanced practice prescribers and a psychiatrist. And actually Kansas now has a psychiatrist who is perinatal specialty is coming to Kansas. So we're very excited about that. There is training available. You can learn about best practices and resources. There is the screening tools, the Espert toolkit. Again, this plug and play, one-stop shopping, go in, look at all the resources that are available to you. And again, Postpartum Support International, lots of phenomenal resources and training if you're interested. Okay, next slide, please. All right, here is the contact information for the consultation line. Monday through Friday, it's going to be answered. We have great resources in terms of licensed social worker answers that phone and really helps sort out what it is you need and helps you get you connected with the resources that you need. There is a web contact form. So if you wanted to go on, you didn't want to place a phone call, you can drop it in a little email and they will reply to you. And there is a little YouTube overview. And this is the link that just, I think it's about a 3-minute video about the KCC perinatal provider consultation line. All right, next slide. Again, more information. And then we're down to my resources. I think we have about 2 minutes. If there are any questions, I would welcome a question, or if there's anything that I need to clarify. Well, I would say that was easy.
I have a question.
Okay.
So sometimes I see moms 2 to 3 days postpartum, and that's, can you hear me okay?
Is this Nanette?
Yeah.
Okay.
So sometimes I see them 2 to 3 days postpartum because of breastfeeding issues. And we know that's the window for baby blues. And so when I give EPDSs, sometimes I feel like they're not accurate because of that window that we're in. And so I was just wondering what you would recommend. Like, moms are feeling sad, they're recovering, they might have had a C-section, traumatic delivery, like all that's so fresh. And it looks different if I see them a week later.
Yes.
So what's your recommendation?
When you've done the EDPS, have you had anything that showed up that it was like 20?
No, but our policy here is 10 or higher. We refer on to, we let the client know that that's our policy, and if it's 10 or higher or a positive on the 10, that we would reach out and let their provider know, and then we follow up with them and do all that kind of stuff. So women are concerned if they're just in the baby blues, and then all of a sudden I'm screening you and it's like, oh, I've never had anxiety or depression, and now it's new to me. And then there are women that have had a history of that, and it's like, you know, like it's not as shocking or life altering to hear that. So
Well, one, I heard you say we have a policy, so I think you have to follow your
we do, and I do follow the policy, but it's just it would just thinking, you know, myself, I'm just like, oh, that 2 to 3 day window is pretty, you know, hard day.
That's
hard
right.
place. Yeah.
So, you know, I think you could frame it up and say, especially, you know, if you've done this enough and you've circled back, you might really have a feel for that and be able to say, so you're going to follow your policy. You're still for them. If you see them in 7 days and that's really sort of resolved, or their number goes down to 5, then maybe they don't have to have an, you know, maybe you wait. The likelihood that you're going to get them an appointment, unless they're in crisis,
right,
you're probably not getting people in 7 days or 10 days. Is that correct?
Well, we have a good relationship with our OBGYN group in town, and they reach out pretty fast to their clients. So,
okay. Well, better safe than sorry. So I would say continue to just follow your process. And, you know, and I think you could use it as an opportunity to even talk to the mom about, you know, your scoring, but I wonder if, just give them some of that information, because that may actually decrease their anxiety a little bit.
Yeah, I kind of sometimes just, I don't know, of course I follow policy. And my other question I had was, some parents don't feel an immediate attachment or love for their baby. And we know that can be normal and it can kind of work its way out. And sometimes that's surprising for new parents, and they're scoring okay on the EPDS. They don't have that anxiety or depression or anything. But again, they're in that little window of no sleep, maybe a traumatic delivery, and they're just like, I have this little being here, you know. So what's some feedback I can give to them that's helpful?
Yes, I think when you don't know what to say across whether there's anything, is to state the obvious. Okay, that will never land wrong. Like, that would be hard, right? Or to say, and it sounds like you've got some experience, to say, you know, I've worked with moms or dads. What you've been through, and sometimes this is a little slower and it's not abnormal. EDPS is fine. You're able to function. So validate what they've been through and their experience, and frame it. I would frame it that way. I would validate, normalize their experience, right? To decrease shame and humiliation. Somebody feels shame, like, oh, I shouldn't feel this way. The way I'm feeling is wrong. Will interfere with communication, right? And if they're, you know, when they're upset about it, to say, you know, it would be really hard. But this is what my other clients have taught me, right? A lot of what I know is what my patients have taught me.
Right.
And, you know, you might even ask, because I do believe that people are experts in themselves. They often don't know how to kind of put together the puzzle pieces of their life to create kind of a cohesive picture. That's where, you know, I come in. But people are experts in their experience. If you have a mom who has had postpartum depression before, she's most likely going to have postpartum depression.
Right.
If it's a new mom, a big risk factor for postpartum depression is having, or postpartum depression that looks more like bipolar illness. A little probably off topic, but if you've had a major depressive episode before the age of 18.
Yeah, the history definitely.
Yes.
The story.
And if, as you're working with moms, if you ever have anybody who is psychotic, that is an emergency.
Right. And I've had dads ask me, when do I know? And I have a really great handout. And I'm like, you take her to the ER, like you call 911.
Because those moms have bipolar illness. And so psychosis and self-harm are emergencies.
Right.
But it sounds to me like you've got a good kind of feel for it, you know? And I don't think that sometimes people worry with mental health, like if I say one thing, you know, I'm going to somebody
over.
I'm not going to, because I'm not that powerful. I can talk to people about self-harm without them wanting to kill themselves.
Right. Good. Well, thank you.
Yeah. Sounds like you're doing a great job.
Thank you. Those are just 2 questions that stuck in my mind that I'm just kind of played around in my head a little bit.
And again, when you don't know what to say, state the obvious. That would be hard. That would be scary. Or sometimes things can be so hard that I would say, man, I don't even know what to say.
Okay, thank you.
Yeah, thanks for talking to me. I appreciate it. All right, anything else?
I haven't seen anything come through in the chat.
Well, I know it is at the end of the day. And so I appreciate everybody kind of hanging around and joining me today. I appreciate your time and your attention. Thank you.
Thank you, Dr. Whitney. We really appreciate your time and your expertise. This was a wonderful session, and thanks to everyone who was able to join us for it. Make sure you tune in again. We're back tomorrow afternoon, same time. Got another great round of sessions coming up. So we'll see you back tomorrow. Thanks again, Dr. Whitney.
You guys take care. Keep up the good work. All right, bye-bye.